Welcome to this evening symposium. My name is Jean-Frédéric Colombel. I'm head of IBD Center at Mount Sinai in New York, and I have the pleasure to chair this symposium. And I have two fantastic speakers today with me, Professor Geert from AMC in Amsterdam, head of the IBD Center as well, and Professor Pariente from Lille, where I was before, and with also the head of IBD there. So the title of the symposium is Keep Calm and Treat to Target to IBD. I think you have seen a lot of advertisement about that, so we will try to explain what does that mean. So these are the goals of this symposium: to highlight the importance of early diagnosis, assessing prognostic factors and treat to target in IBD, to discuss key elements of Thai disease monitoring and assessing response to therapy, and how anti-TNF therapy can be adjusted to optimize clinical outcomes. And then, a very important point, considering the health economic benefits of a treat-to-target approach in IBD. So, we will welcome a lot of questions, because it's a very new area. It's talking about new strategies. So please write your question for the faculty on question cards and hand them to AbbVie people in the audience. And at the end, please complete the feedback form and hand it as you leave. So I will start by a short introduction, just to make the point: where are we regarding the care of IBD in 2017? So we have made progresses, this is very clear, especially since the era of biologics happened, but still, I mean, these are quite depressing data, especially in the US. As you can see on the left-hand side, this is a nationwide inpatient sample, and showing that the rate of fistula repair from 1993 to 2004 actually has not significantly changed. And in another study, we also found that the number of patients who had a small bowel surgery leading to small bowel failure has actually not changed. On the right-hand side, this is also population-based data from Olmsted County. And as you can see, there is a significant decrease in surgeries for Crohn's disease, but still, after 10 years, the rate of surgery is approximately 40%. So there is a gap, and there is unmet needs. So there is data also, especially from Scandinavia, about the burden of IBD, and this is work disability from Norway. And as you can see on the left-hand side, this is disability because of Crohn's disease in blue. And as you can see, almost 30% of patients with Crohn's disease were considered disable, especially in their 40s and 50s. And in UC, a little bit less, like 10% of patients in their 30s. So I think this is one of the most important slides, which was designed by Benjamin and my late friend Mark Lehmann, which I think has completely changed the paradigm of the treatment of Crohn's disease. In the past, we were considering Crohn's disease as an intermittent disease with flares and remission, and so on and so forth, and we were measuring only the inflammatory activity using the CDI, the CDIS, and CRP. But then we realized, and this was late as compared to rheumatologists, for instance, that Crohn's disease is a progressive disease. Each time you have a flare, this is leading to bowel damage, such as strictures, fistula, and abscesses, and then the ultimate damage, which is surgery. And this is why, with Benjamin and Mark, we built this new index that he will be talking about, the Lehmann index, which is an index of bowel damage. And as a consequence of bowel damage, you have disability, which is also a very important point. This is still a question which is not solved. Is UC a progressive disease? I believe so. There are less data about that, but we know that, for instance, UC can extend when you start with a E1 proctitis or E2 left-sided colitis. This can extend to pancolitis, and in my experience, this has the most difficult forms to treat. And something which has been completely forgotten is that actually UC is not only a mucosal disease. There is also actually inflammation in the submucosa and fibrosis. And as a consequence of that, you have this narrowing of the colon, this loss of function which has been completely forgotten, leading to the most distressful symptoms in UC, which are urgency and incontinence. So this is the second key point of my introduction. The goal of the treatment now, and Benjamin will insist on that, is basically to control the progression of Crohn's disease. And if we want to do so, we need to treat patients as early as possible. And this is a concept of window of opportunity. And if you miss this window, then the disease will progress. And when you will see the patient for the first time at your visit, you will already see a patient with complications such as strictures or fistula. So the management of IBD has evolved. It's currently still clinical, sustained remission and no steroids. As you know, the new target is endoscopic healing. Because this is associated with steroid-free remission, less hospitalization, less surgery, and improved quality of life. And in the future, we are even thinking beyond to this concept of deep remission, which is clinical and endoscopic and maybe transmural healing to reduce and prevent intestinal damage and thus reducing and preventing disability. So this is a slide which is basically summarizing what is the concept of treat to target. So the aim is to avoid development of serious complications and disability in patients with chronic condition. This is a concept that basically applies to all immune diseases. Then you need to treat to a predefined treatment target, which will be associated with optimal long-term outcomes. Then you need to have a strategy. You need to do ongoing and regular monitoring of the target and of surrogate markers with optimization of treatments when the target is not met. And you have additional principles which are also key. All components, target, treatment, and monitoring need to be tailored to the needs of an individual patient. And Benjamin will also insist on that. And it's very important because you need to enroll the patient in this concept. The patient needs to adhere to this concept if you want success. And something very interesting that we are exploring as well, de-escalation of therapy may be considered when the treatment goals are achieved. So to summarize, a treat-to-target approach involves predefining a treatment target in consultation with the patients, continuous monitoring of disease activity using objective data, and changing the treatment until the target is reached. So now we will welcome Benjamin from Lille. We will talk about the importance of early diagnosis and treated to targets in IBD. Benjamin, thank you.
Ladies and gentlemen. So, to really understand the importance to make an early diagnosis and to apply a T2T, a treating to target strategy in IBD, we should first understand why we should treat IBD patient as the earliest as possible. Indeed, we know now that Crohn's disease and also ulcerative colitis are chronic and progressive disease. Unfortunately, all the current available indexes we have only assess inflammatory activity. It could be clinical inflammatory activity, endoscopical inflammatory activity, or biological inflammatory activity. But all these indexes could be equivalent in a patient with a very early Crohn's disease and in a patient with an old disease. And we definitely need to have new instrument to catch the progression of the disease and to catch damage progression along the accumulation of structuring lesions, penetrating lesions, and also surgery. And the consequences of that is that we also need new tools to assess the progression of disability and the alteration of quality of life. That's why the first IBD disability index has been developed and recently validated. And that's also why we have developed the first digestive damage index in CD, named the Lehman Index. To assess digestive damage in the whole digestive tract, we have divided the whole digestive tract in 4 organs: the upper tract, the small bowel, the colon and the rectum, and finally the anus. And each organ has been divided in several segments. And on each segment, we have searched the presence and the severity of structuring lesions, of penetrating lesions, and on previous surgery. And we have showed in this first study that clearly damage increased with disease duration, with very lower level of Lehman index in patients with early disease, meaning with a diagnosis within the 2 first years, compared to patients with old disease. And that's very important because that's clear that there is, at the beginning of the history of IBD, a window of opportunity in which we have to identify patients to introduce an intensive treatment to prevent and avoid damage progression and disability progression. So clearly, there is a gap just after diagnosis in which we can stop the progression of the disease. Moreover, some data strongly suggest that anti-TNF treatment are probably more efficient in early IBD patients. Regarding CD and the results of the SHARM study, we know that adalimumab is clearly more efficient than placebo in all CD patients. But regarding the rate of clinical remission, the best results were obtained with adalimumab in patients with early Crohn's disease. And these results have been confirmed in this very recent South Korean study, comparing patients who received early anti-TNF and or early immunosuppressant treatment compared to patients who received late therapy. And in this study, authors reported that patients who receive early immunomodulators and or early biologic had significantly less intestinal surgery and a better outcomes regarding disease progression, with less rates of structuring complications and less rates of penetrating complications. Concerning damage, we have recently performed in Lille a prospective study assessing the Lehman index in 130 CD patients. And first, we confirmed that damage clearly increased with disease duration. But we also showed that patients receiving early anti-TNF treatment had lower level of Lehman index, low level of damage, compared to patients who receive late anti-TNF treatment. So there is data that strongly suggests that early introduction of anti-TNF could prevent damage progression and could maybe change the natural history of CD and maybe of IBD. But we definitely need modification disease trial to show if it's clear or not that this early intervention can change the natural history of the disease. And the first disease modification trial is currently in process in the Jeet centers. Its name is CURE, for changing the course of Crohn's disease with early use of adalimumab. And there is 2 main goals in this study. First, to assess if an early initiation of adalimumab could decrease bowel damage, disability, and surgery 5 years after diagnosis, and also if this early initiation of adalimumab could allow us, physicians, to decrease or even to stop as soon as possible the treatment in case of deep remission, in order to avoid adverse events at long term and to reduce healthcare costs. So probably we need to introduce early intensive treatments in some IBD patients. But it doesn't mean that we should apply this strategy in all IBD patients. That's why we need to stratify patients for a personalized therapeutic strategy in CD and in UC. And we definitely have to make the difference at an early stage of a disease between patients with indolent disease who don't deserve an aggressive strategy and patients with an early aggressive disease who clearly deserve to receive an early intensive therapy to avoid complications. And if we only take into account the Paris definition, for instance, of early CD, it defines early CD by a disease duration for less than 18 months in a patient who didn't receive any immunomodulators or any biologics. And if we only take this definition to introduce intensive treatment, there is, of course, a high risk of overtreating a significant number of patients. So we need to perform prospective cohort to identify early predictors of aggressive IBD to introduce intensive treatment in a subgroup of patients with early aggressive disease. And for this, we should focus on this study, the risk cohort, which is an inception cohort study involving at least 1,000 pediatric early Crohn's disease patients. And in this study, authors clearly reported that there was an allele gene signature associated with development of disease complications, but also biological marker associated to the risk of developing structuring lesions and also penetrating lesions, such as the positivity of CBR1. So we need to perform the same study in adult CD in order to clearly identify clinical, biological, and probably genetic factor for early aggressive disease. But awaiting for the results of this study identifying predictors of aggressive disease, we need from now to modify our strategies and to probably apply the treat-to-target strategy. The T2T concept is very simple in IBD. When you introduce a treatment, you need to define a target. It could be a clinical target, a biological target, or an endoscopical target, or even a composite target. And if this target is not reached, you clearly need to intensify the treatment or to switch the treatment in order to get these targets. And if you will look at the IBD T2T recommendation in CD, you can see that this target is clearly a composite endpoint associating clinical remission, patient-related outcome remission, and also endoscopic remission. And it's the same for the recommendation in UC concerning the T2T, a composite endpoint with clinical and PRO remission and endoscopic remission. And now we need to start and to design study comparing a conventional management to a T2T strategy in order to see if applying the T2T strategy could prevent the progression of the disease. And it's the case of the REACT-2 study, which is currently in process, that compares in different centers a conventional strategy, a step-up strategy, with an accelerated step-up strategy based on the results of the ileocoloscopy. And what is very important in this study is that the primary endpoint is the risk of CD-related complication at 1 year. And the definition of CD-related complications include CD-related hospitalization and the occurrence of bowel damage. So we can see with this study if a T2T strategy can reduce the risk of hospitalization and can reduce the risk of occurrence of bowel damage lesions. But again, the T2T is not a global concept. It should be a tailored and personalized approach to each patient. And of course, the target should be very different in patients with early IBD and in patients with late IBD. In an early stage of the disease, we need to have the absence of symptoms, no disease progression, no complications, no disability, and a normal quality of life. In case of a patient with a late disease, the aim is probably to stabilize the symptoms, to avoid the progression of the damage and to prevent the progression of disability and to improve quality of life. At the end, yes, it's very important to make an early diagnosis and to apply a T2T strategy in IBD if we want to change the natural history to prevent intestinal damage and to prevent disability. And for this, early therapeutic intervention and the T2T strategies are key goals to achieve better long-term outcomes in IBD. But again, treatment target should be personalized, should be adapted to an individualized monitoring plan, and in early disease, we should select the best candidates for an early therapeutic intervention in order to attain deep remission, to avoid disease progression, to avoid complication, and to avoid disability. In case of late stage of disease, we need to stabilize the symptom to avoid the progression of damage and disability and to improve quality of life. Thank you for your attention.
A few questions now before the general discussion at the end. This is a very nice concept. I will now tell about the reality, especially in the US, what I'm seeing. You know, very often we see patients who are not diagnosed, like maybe they have symptoms for more than 2 years before being diagnosed. Second, there is this study presented by Corey-Siegel at ECHO 2017, showing that 70% of patients are started either on 5-azar or steroids, and actually the penetration of biologics after 3 to 5 years is less than 5%. Mm-hmm. So it's very nice to be here on stage and to talk about that. How do you think we can improve this access? You know, how we can improve so that we will have access to patients early and not miss this window of opportunity? Do you have some initiative to propose?
From right now is difficult, but we need to have studies showing that this strategy is better regarding, the rate of complications and so on. If this result will provide, we could have, strong data to convince patients to apply this strategy. But today, probably the aim is to explain to the patient that it's a personalized strategy, and the aim is not to treat them with a very strong treatment for all the life, but it is a window of opportunity to treat the patient in order to stop or at least to decrease the treatment as soon as possible. And I think that we should really insist on this point with these patients in order that they understand that the aim is to get a deep remission as soon as possible to avoid, sustained treatment. And I think we should focus on this point.
Geert?
Yeah, well, I wanted to add it maybe not only in the US, but there was a survey by AbbVie about how long patients had symptoms before the diagnosis of Crohn's disease was made. And like 20 or 25% of the patients had symptoms for more than 3 or 4 years before they were diagnosed with inflammatory bowel disease. And then the investigators in Milan found out that the majority of those patients already had irreversible damage on their MRI scan. Mm-hmm. So I think if we can win somewhere, there's the greatest benefit, the greatest gain is probably to be made in earlier diagnosis. Now, that is a challenge. And I think it has to do with awareness. And IOIBD is investigating a strategy, what we call the Red Flags Initiative, led by Silvio Danese. And it's a very simple tool. It's only 8 or 10 questions, and you have a positive answer to 4 of them. You should have some investigation to rule out Crohn's disease. And it's like, do you have a family history? Do you have joint pain? Do you have diarrhea once in a while? Red blood, very simple things. What's your body weight? And so if that questionnaire would be implemented, and we're now validating that in the GP setting, general practitioners, so once that is validating, we can, and AbbVie can as a patient association, distribute that throughout Europe, maybe also in the US, and really increase awareness, because that's really where we lose our patients to surgery and to all those problems because of late diagnosis. How many patients do not present with a perianal abscess as the first presentation? Still common.
It's my pleasure to present the result of the CALM study. which is a long story. Actually, we designed this study with Marc almost 10 years ago, showing again how Marc was a visionary. So we know that in Crohn's disease, it's not known whether this concept of tight control, meaning making decision based on monitoring of biomarkers, leads to improved patients' outcomes. So CALM is a prospective, open-label, multi-center, active control phase 3 study designed to evaluate 2 treatment algorithms in patients with Crohn's disease. It was not designed to assess the efficacy of the drug. It's designed to assess algorithm. The first one was a classical, commonly done, clinical management strategy. And the second algorithm was a tight control strategy. And then, in both arms, the therapy was escalated according to pre-specified failure criteria. So this is the design of CALM. So this was a big challenge because first we had to recruit, I don't know if this is working, we have to recruit naive patients. That means naive of immunomodulators and biologics. And you know how difficult it is to recruit those patients even 5 years ago. So all those patients are starting according to ECHO guideline with steroids burst, and then they are tapered until week 9. And then they are randomized to 2 different arms. The first arm, which is a clinical management arm, where the escalation of drug is only driven by the CDI and the use of prednisone. And the tight control arm, where the escalation is driven by CDI, calprotectin, CRP, and prednisone use. That means that even if the patient is doing well at these different visits, in the tight control arm, the drug is escalated if one of biomarker is still high. And the treatment escalation was basically following the same scheme in both arms, meaning that first, no treatment if the patient was able to be weaned off steroids with anything. Then, if he was failing, he received adalimumab induction followed by 40 milligram every other week. Then, if he failed, he was switched to adalimumab weekly. And then, the most intensive regimen was adalimumab weekly plus azathioprine. Starting at these visits, and this is original as well, if the patient was doing well, he was able to de-escalate, for instance, from every week to every other week, or to every week plus azathioprine to every other week plus azathioprine. So some patients were early randomized because they were not able to go up to week 9 because their CDI was more than 220, and then they had more than 4 weeks of steroid treatment, and the investigators thought that it was better to taper rapidly, especially, for instance, when the patient was intolerant to steroids, or if the patient was thinking that this was of the best interest for the patients. And then, when the patient was failing after randomization, and then it was moved to a rescue group. And in the rescue group, patients were moved if they have CDI more than 300 for 2 consecutive visits, 7 days apart, or per investigator discretion. So, elevated CRP, calpro, ulcerations were taken into account, and all those failures were moved to the tight control group. So, these are the failure criteria in both arms. From week -1, which is just before randomization, and then at following visits, week 11, 23, and 35. In the clinical management arm, failure was considered if the CDI decreases by less than 70 points compared with baseline, or was still more than 200. In the tight control arm, at week -1, failure was considered if the CDAI was more than 150, or CRP more than 5, or Calpro more than 250 micrograms per liter, or the patient was still on prednisone. So it was really tight. Then at the following weeks, in the clinical management arm, failure was considered if the CDI decreased less than 100 points compared with baseline, or CDI was still more than 200, and the patient was still on prednisone. And in the tight control arm, again, same criteria as far as CDI, CRP, and Calpro, and the patient need to be weaned off steroids. So again, clinical management only, or management based on symptom plus biomarkers in the tight control arm. These are the inclusion criteria: adult patients with ileal colonic or ileocolonic Crohn's disease, with moderate to severe Crohn's disease, with or without systemic steroids, and we consider different levels of CDI according to the steroids that the patient receive at baseline. All patients, and this is very important, of course, had to have active endoscopic Crohn's disease as defined by the CDIS more than 6 and a sum of CDIS subscore more than 6 in at least one segment with ulcers. CRP had to be more than 5 and or Calpro more than 250 micrograms per gram at screening. So this is key. All those patients were included with clinical evidence of disease activity and objective evidence based on biomarkers and endoscopy. There were some exclusion criteria, such as previous or current biologic or immunomodulator use. Again, all those patients were completely naive, or those who received 2 previous courses of steroids or currently receiving steroids for more than 3 months before screening. The primary endpoint was endoscopy. It was a target. Actually, it was endoscopy killing as defined by CDIS less than 4 and no deep ulcers. And there were a number of secondary endpoints that you can see here, such as deep remission, biologic remission, mucosal healing as defined only by the CDIS, mucosal healing in all segments, complete endoscopic remission, which is a very tough endpoint, meaning CDS 0, endoscopic response, which is a decrease of the CDS of at least 5 points, and very relevant clinical endpoint, of course, the steroid-free remission. So this is a patient disposition in CALM. So we screened 460 patients and enrolled 244. Many of them didn't meet the inclusion criteria, for instance, at endoscopy, which is quite well known. And they were randomized to the clinical management arm or the tight control arm. Interestingly, more than 55, or approximately 75% of patients had study completion, which I think is quite remarkable for a study. And on the right-hand side, you have the different reasons for discontinuation, such as adverse event, withdrawing of consent, loss of follow-up, of lack of efficacy. So this is the baseline characteristics of CALM. The most remarkable, of course, is disease duration. I think this is the earliest population ever studied in a clinical trial with an anti-TNF, because the mean disease duration was less than 1 year in the clinical management arm and just more than one year in the tight control arm. So very early patients. All patients had active disease based on CDAI, CDIS. As you can see, the disease location is as usual. And you have the patient with Calpro and patient with high CRP. Actually, more than 80% of patients in both arms had elevated Calpro, and same is true for CRP, 84% and 78%. So quite active patients. And you have the percentage of smokers and the IBDQ, quality of life index, which was comparable in both groups. So this is the primary endpoint of CALM at 48 weeks, which was highly significant. the percentage of endoscopy killing was 46% at 1 year in the tight control arm, which is quite remarkable if you compare with everything that has been observed so far with all drugs, as compared to 30% in the clinical management arm. So higher rates of mucosal healing and no deep ulcerations was observed in early Crohn's disease when treating to target and treating with these biomarkers was compared with symptom-driven clinical management alone. The study was also strongly positive for a number of secondary endpoints, such as deep remission, defined as a clinical remission, no steroids and endoscopy killing, biological remission, which combine CRP, Calpro, and endoscopy, mucosal healing just defined by the CDIS, and there was superiority, but it was not significant for mucosal healing in all segments, complete endoscopic remission, which is also very tough to attain, and endoscopic response, because actually all patients were treated, and endoscopic response was an easier endpoint to reach. So again, most important, higher rates of mucosal healing, and this very important endpoint of deep remission was observed in the tight control arm. So very important and relevant clinical endpoint, which is steroid-free remission, and starting very early at week 11 through the end of the study, week 48, patients in the tight control arm were in steroid-free remission much more often than patients in the clinical management arm, which is very relevant for as a clinical endpoint. So this is a very important slide to understand. It's maybe a little bit complicated. So let me walk you through this slide. These are the different time of the study. So week 0, randomization, week 12, week 24, and week 36. So the treatment could be changed at any point. So the color codes represent different regimen. The gray is no treatment. Then you have light blue adalimumab every other week, which could be from the beginning, or adalimumab every other week coming from patients who de-escalated from adalimumab every week. Then you have adalimumab every other week plus azathioprine, adalimumab every week, and the most intensive, adalimumab every week plus azathioprine. And actually, the most important message, just by looking at this slide, is that it's very clear that in the tight control arm, which is on the right, patients were accelerated much earlier. I mean, the treatment was stepped up much earlier in the tight control arm as compared to the clinical management arm. For instance, at the end of the study, as you can see, all those patients in the clinical management arm were still on adalimumab every other week, while the treatment was much more intensive in the tight control arm. So this is important also to know why patients were escalated. And in the tight control arm, at basically all visits, the most important driver for escalating was calprotectin, followed by CRP, by CDI, and the prednisone use. In the clinical management arm, the most important driver was actually the need for prednisone, followed by the CDI. So what you can expect is that because we are introducing a more intensive treatment earlier and globally more drugs within 1 year, what we could expect would be more side effects in the tight control arm. Actually, this was not at all the case, and even when you look at the number of serious infections, the number was higher in the clinical management arm as compared to the tight control arm. And basically, there was no new signal. The safety data are very comparable to what has been observed with adalimumab so far. So to conclude, this is the first study to demonstrate that a tight control approach using objective data, using biomarkers, is improving outcomes in Crohn's disease compared with symptom-driven care only. So managing patients with Crohn's disease by clinical symptoms alone may not adequately control the underlying inflammation. And biomarkers, which are very simple to use, can guide treatment dose increases that lead to superior endoscopic and clinical outcomes. And finally, the tight control approach did not lead to increased safety signals.
Already a first question for you. Around 25% of the patients in the tight monitoring group were able to set a step back in the treatment at a certain point in time. Now, these were patients that were in remission. Was that supported by the biomarkers that they were in remission? How long were they in remission? And might it have an impact if we had not decreased treatment in those patients?
This is a good question. I didn't look at that. I suspect that those patients were also in remission by biomarkers, but I don't know for how long. So answer your question.
Because it was, if you've seen the risankizumab that data with the P19 antibody, there the patients who were really in deep remission, endoscopy and clinically, and the drug was basically stopped, they were in remission like for very long on no drug. So I wonder whether these patients, we don't know whether they were in endoscopic remission. We don't do endoscopies. So it would be interesting to look at the biomarkers in these patients.
Good point.
Maybe I have two questions for you. The first is more an interrogation, a philosophical one. What is the difference between the tight control and the T2T?
So yes, I want to clarify that, and this is my fault actually. So again, as you described, the treat to target is actually treat to target, and the target is endoscopy plus clinical remission. Okay. And this study, the Icahn study, and actually when it will be published tomorrow, it's tight control. So the tight control is a way to reach the target. Imagine that you are trying to reach the target, you are helped by these biomarkers, which facilitate to reach the
Yeah, I think if anything,
this is a very important point. Thank you for
if
asking
column
this
is a treat to target study, then the target was biomarker remission, basically.
Exactly.
Yes,
and indirectly that led to
strategy
more.
or biomarkers.
Yeah,
and we can say
because we were treating
maybe.
to basically normalization of biomarker, but the ultimate target was endoscopic healing.
Yeah, that was a readout, basically.
Yes.
And my second question is that the Icahn results suggest that we should treat with a tight control strategy all patients with ulceration in the colon?
So this is a very good question. Actually, how can we translate this, the result for this clinical trial in clinical practice? Because this is always
The question.
I think the most important message to me is that you need to monitor patients, not only on symptoms, but with biomarkers. And then, and as we are doing, this is this concept of tight control. Because if you are just looking at symptoms, you will miss something. Some patients may progress, it will be under the tip of the iceberg, and then this will lead to damage and disability. So you need to monitor biomarkers and then take your decision based on symptoms and biomarkers. So how will you apply that in clinical practice? So you will measure these biomarkers. When the biomarkers increase, maybe you will repeat, or you will exclude another reason. For instance, if CRP is increasing. Maybe if you want to confirm, you could perform an endoscopy, but this is a red flag. That means that something is not going well in this patient, and you will need to escalate. This is my clinical take-home.
So we measured two biomarkers in addition to the symptoms. That you think we could do even better by adding more parameters, for instance, the serum concentrations of drug or other proteomics or so?
No, I think this is very, very good point as well. We will look at the pharmacokinetic data, and maybe if we add the drug monitoring on the top of biomarkers, we can do even better. And as you know, and Geert, you know that better than me, there are now new tools, maybe serological tools only, that may be very good surrogate markers for endoscopic healing. That maybe could be used for the same concept.
So maybe we may end up without endoscopies at the end of the day. I'm sorry for that.
Exactly. Okay.
Jean-Fred, well, ladies and gentlemen, you have all seen that we have used considerable amounts of drug in this trial, and the question is really, how much did we need to spend money-wise, and did it pay off at the end of the year of treatment? So it's not only about financial cost, though, inflammatory bowel disease. When we think about inflammatory bowel disease, the disease has an impact on the personal quality of life, on physical well-being, concerns for family related to pregnancy, for instance, psychological well-being, expectations for the future. So basically, of the cumulative burden of IBD on a patient, the finances is only like one aspect of a whole range, so we have to keep that always in mind. So if we now think theoretically what the potential benefits could be of optimal use of the available treatments when we apply a treat-to-target approach in IBD, but mainly in Crohn's disease, which is the topic of this symposium, well, achieving sustained deep remission is definitely of value to the patient. We know that. And that probably is accompanied by a reduction of intestinal damage, like Dr. Pariente has shown, reduced complications and reduced disability. And that then secondarily leads to a reduced need for surgery. Extraintestinal manifestations will disappear. And as we've seen in 25% of the patients, we were able to withdraw treatment, or at least one of the treatments, to a certain extent. In children, it is very important, children and adolescents, to restore normal growth, so that's an important aspect. For adults, it's important to be able to go back to work and have a normal social functioning. And when I saw this slide, I added one box here at the end of the slide, which I think should be the ultimate goal in our IBD management, which is return to normal life. That really should be the eventual goal. Okay? So we've just seen the trial and the data of the trial, and you've seen that symptomatic and endoscopic remission was reached more frequently when a tight control approach was used compared to conventional clinical management. And tight control was based on symptoms plus two biomarkers that we all use in our clinic, C-reactive protein and fecal calprotectin, and that led to an increased use of adalimumab in the tight control group. But you've also seen that more intensive immunosuppression, more adalimumab, more azathioprine, did not result in increased toxicity signals, at least during the year of the trial was performed. And here we're just looking at the serious infections, and you will immediately appreciate that, for instance, for perianal abscess, that was a bit counterintuitive, was even more frequently seen in patients that were in the conventional clinical management group, 4 abscesses versus 0 abscesses in the patients who were in the tight control group. And all the other infections occurred like equally frequently, even a bit more frequently in the clinical management group than in the tight control group. There was one sepsis in the clinical management group, being the most severe infection that we observed here. So let's now look at a number of other outcomes that are very important to the patient and that you haven't seen in the previous presentation. And those events occurred in the first 48 weeks, the duration of the trial, and were very important when we think about cost, okay? There were Crohn's disease-related hospitalization, and the definition was any overnight stay in the hospital that was related to Crohn's disease up to 70 days after the last dose that adalimumab was given in this trial. Then you have surgeries. Crohn's disease-related surgical procedures that we split up into 2 categories: the major Crohn's disease intervention, resections, stomas, stricturoplasty, or drainage of abdominal abscesses. Then the non-major, you could also say minor Crohn's disease-related surgeries were abscess drainage, set-on placement, fistulotomy, or placement of a TPN access line. Okay. Then the adverse outcomes were pooled in a third endpoint, Crohn's disease-related hospitalization or serious complications, basically a pooling of all serious adverse outcome, and then also time to Crohn's disease-related flare, or flare being defined as an increase in the CDI score of at least 70 points from 1 week prior to randomization, and a total CDI score above 220, so clearly representing active disease. So looking at the hospitalizations, and Dr. Panaccione showed this at one of the sessions earlier today, you immediately see there was a clear difference. There were much fewer hospitalizations in the tight control group, 14 hospitalizations versus more than double, 29 hospitalizations in the conventional management group, and that was clearly highly statistically significant. Okay. What about Crohn's disease-related hospitalizations due to an emergency? Patients came through the ER in the hospital. You see that the difference was not statistically significant, probably because there were too few events for emergency hospitalizations in the tight control group versus 11 hospitalizations in the clinical management group, so numerically quite significant. What about the incidence of the Crohn's disease-related hospitalization or serious complications, so the pooling of the important adverse outcomes, okay? In the tight control, 14.8% of the patients. In the clinical management, 20.5% of the patients. Again, not statistically different, but numerically, there is clearly a trend here, okay? What about the Crohn's disease-related surgical procedures? And think of it, we're only looking at the patients for a year, which is kind of short in the disease history of a Crohn's disease patient. But nonetheless, fewer events in the tight control group, 7 surgeries, 9 surgeries in the clinical management group. And then the time to Crohn's disease-related hospitalization or serious complications, so the pooling of the adverse outcomes, no significant difference, but a numerical longer time to a severe adverse outcome in the tight control group. The same is true for Crohn's disease flare, but here we do see quite a statistical advantage in favor of the tight control group, much fewer, much later relapses of the Crohn's disease compared to the tight control group. Okay? Now, I've alluded to the 1 year that this trial may perhaps have been a bit short. And we typically do 1-year trials in Crohn's disease. It's been exceptional that trials lasted longer, and so I'm very much in admiration for the Geert group that they launched on a 5-year trial, which is really exceptional when you think of the wildest results that may come forward from that type of approach. But we did one other trial that we followed patients for 2 years, the REACT-1 trial. Benjamin alluded to the REACT-2 trial, which is endoscopy-driven, but the REACT-1 trial was driven by symptoms. So here we looked at patients with Crohn's disease that were followed in 2 groups of IBD centers. And one group of IBD centers treated the patients by their usual care. And the other group of IBD centers, an other cluster, it was a cluster randomization trial, saw the patients back every 3 months, and when they were not in clinical remission, the treatment was escalated. So no endoscopies, no biomarkers, just by clinical outcome, CDAI, and the treatment was escalated from adalimumab to weekly adalimumab, to another antimetabolite, switch to TNF antagonist, and then finally consider resection. So really a build-up at every 12-week visits, basically, until the patient was really in remission, which was the goal of the trial. And what we observed here, and you must have seen, or perhaps you've seen the publication in the Lancet already 2 years ago, that in the first year of follow-up, we did not see a difference in any adverse outcomes. For instance, hospitalization, surgery, or serious disease-related complication, no difference in the first year. Fortunately, at the beginning of the trial, we decided that this needed to be a 2-year trial. So we followed the patients for another extra year, and what became clear that in the second year, the curves clearly separated in favor of the rapid treatment escalation based on symptoms. So imagine what will happen now in REACT-2 when we decide to escalate treatment based on endoscopy. So most likely we'll have much more separation of the curves. I'm really thrilled to seeing the data, but I'm afraid it's going to be another year or two before we have those data. So now I'm going to take you to something really difficult, an economic model. We doctors, we don't think too much about money, I hope, but this is now a pharmacoeconomic analysis based on the CALM data, and it's quite interesting what we see in terms of outcome here. So at any point in time, the patients were categorized by their disease state based on the CDAI. They were either in remission, or they had moderate disease activity, severe disease activity, or very severe disease activity. And all those disease states are associated, and we know that from previous models and publications, with a certain quality of life based on the EQ5D. And we know that certain levels of EQ5D are associated with healthcare utilization. Because when you don't feel well, you go to the doctor, or you have a test, or your culture, or an endoscopy. So that cost comes along a lower EQ5D or a lower quality of life. At any point in time also, as I showed, you could be hospitalized. Hospitalization is extremely expensive in the United States. It's also expensive in Europe. But anyway, that's a major driver of expense in healthcare utilization. Okay? So now we have to calculate something that is very difficult to understand, but it's the incremental cost effectiveness ratio. What does our intervention bring along in terms of higher cost, but what do we win in terms of improved quality of life, which is then reflected in something that you will recognize, quality adjusted life years. So here to the right of the slide is what we gain by the investment that we make on the left side on the slide, okay? And so what we win in terms of quality of life is again based on the CDAI, on the EQ5D that is associated with that, and on the reduced cost of those disease states. So what were the direct medical costs that we calculated in this model? Evidently, the cost of hospitalization, and there is a standard cost for that. This is a United Kingdom model because there is most of the numbers and the models are based on UK data, so that's the easiest to apply. So what we did, we looked at the hospitalization rate in the CALM trial, and we multiplied that by the standard hospitalization cost for Crohn's disease in the United Kingdom. Cost of adalimumab was easy to calculate. You know how many syringes were consumed and the patient injected, so we counted the injections in the different treatment arms by the list price of adalimumab in the United Kingdom. That was easy to calculate. And then you have other medical costs which are associated with the reduction in the EQ5D, in the quality of life, associated with certain disease state measured by the CDAI that we had available from the CALM data set, basically. And so bringing the costs then together with the quality of life that we win, that gives you this calculation, the incremental cost effectiveness ratio of what you do in terms of intervention. So looking at costs here immediately, then we see that the patients were much more likely or much more frequently in remission, 62% of the time in the tight control arm versus 47% of the time in the clinical management arm. That's associated with reduced quality of life, and so with a higher healthcare utilization, okay? The Crohn's disease-related hospitalizations, we've seen that data that was observed in 13 events per person year in the tight control, 28 events per person in the clinical management group. Adalimumab, as I said, on average in the tight control group, patients received 31 injections of adalimumab in the whole trial, in the whole year, okay? Versus 25. It's very difficult to inject 24.7 syringes, so let's say 25 syringes in the clinical management in the duration of that year. And here's the cost of adalimumab at the bottom in the tight control, on average 10,870 UK pounds versus 8,705 UK pounds in the clinical management, okay? So evidently, direct medical costs were lower in the tight control group, almost 1,300 UK pounds versus 1,500 in the clinical management, and also the hospitalization cost was reduced from 2,400 almost in the clinical management to 1,100 or so UK pounds in the patients on the tight control. So you're beginning to see the picture There are more drug costs in the tight control group, but there are many more hospitalization costs and other direct medical costs in the clinical management group. And so bringing that together in this model and in the numbers, and now you have to think you live in the UK because we're looking at pounds here, UK pounds. So total direct medical costs, the sum of the individual items that I've explained you, were 13,000 UK pounds in the tight control group, okay? And 12,600 in the clinical management group, which was a delta of 669 UK pounds that the tight control was more expensive. Not only for drug, but also for additional tests that we performed in the trial. What did we win? What were the quality adjusted life years? Okay, so here reflected in the QALYs in the tight control, 1.684 in the tight control group, 1.652 in the clinical management group. You may think this is not a big difference, but think of it. When you multiply that across the whole patient population, it really did make a difference. And if you calculate the cost to gain one QALY, okay, across the intervention, it was around, 21,000 UK pounds, which, according to the NICE guidelines in the UK, is a highly cost-effective intervention, because once you're under 30,000 UK pounds per QALY, then it's considered to be a cost-effective intervention. So I hope I made this very complicated story comprehensible, but that's how pharmacoeconomists think, and I hope you can think a lot. So in conclusion, ladies and gentlemen, I think that tight control in a CALM trial in patients with Crohn's disease led to improved outcomes. We understand that better than money, improved clinical outcomes, reduced hospitalizations, and improved quality of life, but also that the treat to target strategy was cost effective compared with clinical management based on an UK economic model using the CALM data. And with that, I thank you for your time.
So we have now plenty of time for discussion. I will start, but you can please send card, or I don't know, there are microphones as well in the audience. So Geert, I will start with you. There was this question because you presented the REACT-1 data, and actually the impact of the natural history in REACT-1 started after 1 year. Yes. So retrospectively, do you think we made a mistake that just by limiting CALM to 1 year?
Well, it would definitely be a mistake not to follow the patients for longer than 1 year, even if you do not do any intervention. There is a big difference between the REACT trial, which had patients that were under care independent of the disease duration. All comers in those centers basically could enter in the REACT trial. And so even if they were already on biologics, so the population was completely different from what we had in CALM, which was an early bio-naive population. That may also be the reason why the curve separated so late in the follow-up. So that there is a big difference. The studies cannot be compared.
Actually, I have one question. So far, so good. Will you follow up this cohort?
The answer is we will try.
The answer is yes. I have a question now, maybe for you, Benjamin. What do you do with Calpro in real life? Because we were escalating the drug just on one measurement of calprotectin. Are you doing that, or are you repeating the, what's the clinical practice?
So regarding calprotectin in France, it's complicated because it's not reimbursed.
Oh,
so
really?
we don't use it at all. Okay.
Oh, really?
Yeah. And I think that no, we should probably not intensify the treatment with just one result of calprotectin, but probably to confirm this at maybe a 1 month delay with 2 different results of calprotectin, because there is some bias.
There is caution in the use of calprotectin. You need to know the test. You need to do a lot of tests before you understand. First of all, patients with ileal disease may have normal calprotectin while they have active disease. Mm-hmm. So you need to know that in your individual patient. What I recommend always when you scope patients is to also do a calprotectin. Then you understand the kinetics of the calprotectin in relation to the disease state in the individual patient. But in the Netherlands, we're a strong believer of calprotectin. We've now instituted a system that the patient will bring a stool sample, is invited to bring a stool sample at every clinic visit. And you have a machine in the clinic to measure it on the spot. And so I think that will allow rapid treatment adjustment, and I think that's where we need to go.
I think this is
I think that there is not emergency to treat a patient just, on an increased calprotectin
But you need to
level.
react.
But you need, of course, to react and probably to repeat again the exam.
Yeah, it's very interesting. In Telorix, we did 2 measurements on the same samples, and sometimes there was a difference of 100 microgram. So that you have to be very cautious. Certainly in the lower ranges, that there may be quite a difference across measurements.
So, Geert, in the Netherlands, you are very advanced as far as telemedicine, you have this IBD coach and so on. So do you foresee in the future that the patient will do tight control at home? Because there is also this tool that you can measure calprotectin at home. I guess we will have the same tool for CRP. And with your telemedicine system, your My IBD coach, because this will be the perfect way actually to really control.
It depends on the setting. I think My IBD coach is perfect for regional hospitals, many mild to moderate ulcerative colitis patients. In an academic setting where you have a lot of refractory patients, the telemedicine doesn't work well because you run from one problem in the other. But I think we'll have to individualize the follow-up. So intensive follow-up until there's deep remission, and then less frequent follow-up. And that the system will have to change. Now we have this rigid system of visiting every 6 months or so, but maybe when the patient is doing well, it's okay with coming every year.
Geert, I have this question. Actually, this was asked me, but I would like to have your opinion, because the strategy that we did in Cannes was a little bit original, because we started with adalimumab mono, then weekly, then we finished with combo as a most intensive regimen. What do you think about that? This was Mark's idea, actually.
Yeah, well, he wanted to turn the pyramid upside down already 10 years ago, which is kind of interesting. I think that there is a window of opportunity in the induction of remission. And I always prefer to hit the disease very hard in the beginning, and I would personally be in favor of using combination treatment, which we still do with infliximab, adalimumab, methotrexate, thiopurine, it doesn't matter, but combination treatment in the first, we do 6 months, okay? And then once you're certain the disease is in remission, you can begin to withdraw treatment rather than escalate, because you run behind the facts.
This is where the PK data will be very interesting.
And I do agree, because I think that the T2T strategy is the beginning of a non-enough treatment strategy, more than a step-up accelerated strategy.
Okay, Geert, was a question about the indirect costs. This was not measured in Cannes. Do you think it could be also?
Well, no, there is cost associated with reduced quality of life, and what we mainly measure here is indeed healthcare utilization. Indirect cost is very difficult to measure. That's like a day you stay at home because you don't feel well, or you cannot take care of your children, or somebody else does your shopping. How do you put that in money? So maybe the difference is much larger than what we've got, but this model doesn't look at that.
Okay. And then I will answer this question. Is a treat-to-target approach valid in UC? I will say most likely. We have no prospective study, but we have very interesting study with other anti-TNF showing that actually if you can achieve very early endoscopic remission, and even Mayo score 0, even better than Mayo score 0 and 1, and keep the patient in clinical remission for 1 year, this is reducing significantly the risk of colectomy.
That's correct. I mean, but the prospective data that we have is mainly from ACT, and that was combination of 0 and 1, and all the 0 is kind of retrospective. But I agree with you, and I think may even try to push it harder and bring patients into histological remission. That's probably the ultimate goal in ulcerative colitis. But that's a trial that needs to be done. That's, another 10 years, Jean-Frédéric.
Okay. Question for you, Benjamin. What this definition of early IBD? Why 18 months? This was, I mean, that you were mentioning. This is based on what?
It's based on a subjective definition, and that's all. So there is no answer to clearly define why it stayed 18 instead 24 months. It was just a consensus which defined 18 as probably, you know, the best cutoff to treat the patient in order to avoid patient with a significant rate of complication. But it's just a consensus, what we call a Delphi method, and it was just after this. So there is no objective data to define an early IBD.
But don't you think we should look at all studies and do a kind of ROC analysis to define actually what's the best cutoff to
but what's the best cutoff
early
to define what exactly?
To
you know what
define
I mean?
the best time for...
I don't think you will find it.
No.
Because there's too much variation between the beginning of the symptoms and the diagnosis. And as long as that variation is so wide, you
I think the problem of early is not really the early diagnosis. It's again to treat before damage and before complication, regardless the time of symptoms probably.
Okay. Question for you, Geert. One drawback of intensive assessment is a frequent endoscopies. So, do you think that in the future the colon capsule, for instance, could replace that, or new tools that you know?
No, I think
non-invasive.
there is a new capsule now by Medtronic that we're kind of validating. That is the Crohn's capsule. Basically, that has a very long battery life, and you really videotape the whole GI tract, but there is still bowel emptying needed for that, so like a colonoscopy, unfortunately. So it's not so easy as you think of it. Swallow the capsule and you're done. I mean, there's still bowel prep needed. And but the nice thing is that you have the full readout of the small bowel and the large bowel. And so, patients like it a lot, but it's still not without burden to the patient. So I think if we can reduce the number of colonoscopies and imaging overall, perhaps introducing more ultrasounds. I very much believe in that because it's so little invasive that the burden is going down.
And probably also, colonic MRI will be.
Okay. So you believe that in the future this will be
probably.
MRI?
Yeah, probably we can use colonic MRI, and there is interesting data comparing colonic MRI to colonoscopy with, a very high reproducibility of the results. So I think probably in some patients we can use it.
Okay, so thank you so much for your attention. Actually, I kept the best question, which is coming from Sweden for the end. Is Calm the most important IBD publication of 2017? I say yes.